بسم الله الرحمن الرحيم الحمد لله رب العالمين وصلى الله وسلم وبارك على نبينا محمد وعلى آله وصحبه أجمعين. Welcome you all to the continuous medical education by the Oman Family Society in collaboration with the Dakhlya Healthcare Committee and the Nizwa Healthy Lifestyle Project. This CME today is targeting a common management pathway for obesity nationally and internationally, which you are going to encounter, already you are encountering in your day-to-day practice, which is the challenging topics of how to manage post-bariatric surgery, evaluation, nutritional issues, how to assess non-surgical complication, other things. Our CME today is accredited by the Oman Medical Specialty Board, and you need to stay at least 30 minutes with us to get your credit hours. And this CME, of course, you have the chat. If the voice is not clear, you can put your questions there or any queries. We have Q&As session, so you can put your questions on the Q&As. Hopefully, you can answer your questions by the end of the session. And in addition, we'll put some questions polls to you, so you can participate with us actively. And this CME will be recorded and broadcasted in the later on our channel on YouTube, and you can access it through also our link on the Twitter. Today's speaker, our colleague, Dr. Amira AL-Kharusi, and she is board of RCBC and had diploma in ABO obesity medicine and bariatric surgery. She is working now in the National Endocrine and Diabetic Center, and she has high interest in the education of her colleagues in primary healthcare on the post-bariatric surgery care. Dr. Amira, the floor is yours.
Assalamu alaikum. My name is Amira AL-Kharusi, and I'm a specialist in obesity medicine as well as bariatric medicine. I have basically my background training is I have unstable connection, so I will have to disable my video for the time being while I'm presenting. So 1 second.
Okay, Doctora, give me. I'm going to give you. I'm to request a control. Give me a control on this. Okay, now you can. Okay. Okay, we are done. Just a moment, Doctora.
Perfect. So I graduated Sultan Qaboos University 2011, and I have internal medicine and clinical biochemistry specialty from McGill University, and I did my training in bariatric medicine from University of Ottawa. As Dr. Zahir mentioned, that I'm now practicing at the National Diabetes and Endocrine Center. I see patients with obesity, assess them for obesity management, whether it is medical management or surgical management. So I assess patient pre-operative as well as post-operative before we discharge them to a primary care physician. Thank you for joining us today, because I think this is a very important topic to focus on, especially that we are discharging patients sometimes 1 year to 2 years after surgery, and they require special care and attention. And this is hopefully will be a useful topic for you in terms of like management of patients post-bariatric. So the outline of this presentation is mainly that I will focus on the guidelines, especially the new guidelines that came in the last 2 years, and the recommendations for post-bariatric care, and also the non-surgical post-bariatric complications. And that will include the weight regain, nutritional deficiencies, metabolic and endocrinological complications. There will be some others that I will mention briefly, not in details, because I think they are also important, although less common than the 3 that I mentioned previously. So the guideline will be basically targeted for patients who are, for physicians who are taking care of patients while they are in the care for by surgical team, for surgeons, physician, as well as a primary care physician. To start the topic, I think we need basically to give some background why we are doing this topic nowadays, because the prevalence of obesity is growing in Oman and worldwide. And this is a study that was done in 2012 by the OMSB. And I apologize for the quality of the pictures, but this is the best from the paper. So it showed that basically the total number of obesity in Oman is reaching 30%. And this is basically in the range of obesity classes, which is class 1, 2, and 3. And it is mostly in the middle-aged group. So between the age of 35 and 55, we have the highest number of obesity in Oman. And this is the most productive age group, of course. And hence that the impact our population significantly. Since then, and because of all the trend in obesity in Oman and worldwide, bariatric service has been established long ago in many countries, including Oman. So the bariatric service started in Oman roughly in 2017, but I think it existed before that, because we have patients we are seeing sometimes who had bariatric surgery in 2012. So early it started, but maybe non-official, but in 2017 was the bariatric service was started in Royal Hospital. The current number of cases is fluctuating because of different factors, but estimation of the number of cases that is done per year in Royal Hospital is around 190 cases. And the other bariatric centers in Oman include Armed Forces Hospital, Nizwa Hospital, Sultan Qaboos Hospital in Salalah, as well as we don't forget the private hospitals where most patients, I think the majority of patients do usually the surgery in private hospital and private centers, not in the government, because of the long waiting time in the government hospitals. And hence, basically, the importance of this topic actually, because those patients who are doing the surgery in private will probably approach after surgery the primary care physician instead of a specialist in the center. So why bariatric surgery is trending worldwide as well? Because of the evidence behind bariatric surgery and obesity and multiple comorbidities as well that is related to weight. This is the biggest study and the most cited study actually, which is the Swedish obesity study that was the longest since 2007. It is usually 16 years study, which is the longest period of time that studied bariatric surgery. So in this study, basically what it showed that gastric bypass that was done for patients 15 years ago showed, compared to controlled group, showed a more significant weight control. And this is also was translated into basically less mortality and morbidity in patients post-bariatric compared to control group. After this, they published many data from the same population of the study, and one of the most important ones were around the diabetes remission. And this is another way where they actually pushed bariatric surgery as a tool for management of obesity, because it showed significant results in terms of diabetes remission post-bariatric compared to control group, where patients lost the same amount of weight, but they had remission post-bariatric in 2 years, for example, up to 70%. And that was also significant in 10 years, where around 40% still in diabetes remission, and into like 15 years, like around 25% still in diabetes remission. And also that included the reduction in the microvascular and macrovascular complications in patients post-bariatric. So this is why basically bariatric surgery has been one of the intervention that is used for patients with obesity and diabetes especially. And according to many, like media also has pointed this out, when the trend of bariatric surgery has started and when the Royal Hospital also started to do a surgical management, because of the increasing rate of bariatric surgeries worldwide, Oman was one also of the countries that followed that trend, which is the evidence-based practice right now for obesity. Because also of this increase in rate of bariatric surgeries, many guidelines has updated their recommendations to guide basically surgeons, physicians, primary care physicians in management of patients in bariatric service. And many of the guidelines has updated many countries updated their guidelines in the last 2 years. For example, the Canadian guidelines, the last one was in 2008, and they updated their new guidelines in 2020, which is in August this year. And before that, the American guidelines last year guidelines from 2010. Prior to that, the British guidelines, they did not have a prior guidelines specifically, but they updated a draft from previously also known guidelines. So what I'm following usually the Canadian and American guidelines. This is basically because of their prolonged data that they used, and also because the surgery has been done in these areas for a long time. However, the UK guidelines may be the closest to us in terms of the type of surgery that's done in Europe is similar to the type of surgeries that's done in Oman. So in terms of basically the pathway that the patient follow post bariatric is similar to what we implemented in basically on Ontario. So it is similar one that is implemented in Royal Hospital. So
Dr.
it's sometimes,
Amira,
yes.
can we see how much frequently our colleagues are seeing post-bariatric surgery as a whole?
Yes, of course. We can start with that. Thank you for reminding me, Dr. Zahir.
Okay, we'd like to share, your experience of how much frequently you are seeing post-bariatric surgery in your day-to-day practice. Now you can put your answers on the poll itself and click submit. Now we're having 72 attendees on this session. Almost we have 55 replies. I think will be enough. Okay, we can show the result. Doctor, I have the result there.
Yes, so we can see that the majority commented that they rarely see patients with the post-bariatric, and we have usually 32% and never about 7%. So I'm sure this depends on different factors here, but I think those who rarely see patients, maybe in areas where it is less commonly done. If you are practicing in a center where there is a nearby bariatric center, maybe this is where you will see more patients. For example, Dakhlya region, Muscat region, I think, and Sura Suha, they don't have any bariatric centers, and Salala region will be most common areas where you will see a bariatric patient. But as I said, this is a trending practice now, and bariatric is growing. So in the future, probably we'll see more patients. If not now, maybe in the last, I would say, a year or 2 years, probably. So in terms of the flow of patients that are going through the bariatric surgical stream for weight management, usually they are referred by primary care physician, and this is similar to what we are doing at the National Diabetes and Endocrine Center. They will be referred by by family physician initially, and they will be initial assessment by endocrinologist or a bariatric physician at the center. They will be reviewed by my team that includes the bariatric physician, bariatric surgeon, a dietitian, psychologist, and also exercise therapist if you have at the center. And then basically the surgeon consult will be with the multidisciplinary team assessment. The date of surgery will be fixed. The patient will have the surgery, and then post-surgery they will have a shared care model. Sometimes they do basically go to their family physician after surgery for different complaints, and sometimes they go back to the surgeon when post-op appointments. For example, the week 1 post-op appointment, then they have 1 month, 3 months, 6 months, and 1 year. So this is usually in bariatric clinic. Sometimes we see them at the endocrine center as well for assessment of their nutritional deficiencies, their weight, medication management, especially diabetes medication. And then after 1 year, usually up to 2 years, if there is no issues, the patient will be discharged and to primary care practice. And this is where the transition happen. And then following that, usually the primary care physician will follow the patients. The follow-up is usually yearly for those patients as recommended by the guidelines. So what kind of basically visits you will have from patients post-bariatric? Either they come for their annual assessment, or they will come for the weight regain or weight loss maintenance. And this is rare maybe, but commonly weight regain. Symptoms related to the micronutrient deficiencies. hypoglycemia, diabetes management, behavioral and psychological concerns, or symptoms related to surgical complications, which will be beyond the scope of this presentation, as we are going to mention all the above. So the annual post-bariatric assessment, basically the American guidelines has summarized it in a nice table where what you see here is basically what is required from physicians in a yearly follow-up. It is very extensive, but it has also many tests that we don't do here in Oman. However, to summarize it to you, basically the vitals, and the fifth vital will be the weight, which is important because you need to assess the weight trajectory post-bariatric. Adherence to lifestyle, presence of complications, metabolic screen, nutritional screen, adjustment of medication, multivitamin supplementation, bone health, mood disorders, and social support. So these are the bullets that you have to follow when you see patients post-bariatric, and I'll be happy to share actually the clinic templates that I use for post-bariatric patients for assessment. So the complication post-bariatric can be divided into areas. The fresh post-bariatric surgery, they will be seen by surgeons and by physician, endocrinologist, or bariatric physician. So those may mostly include like bleeding, wound infection, anastomosis leak, BTE, or wound infection. So these are early complications. However, you might see the other part, which is the late complications post-bariatric. One of them, like I divided them into mechanical, which would be like stomal anastomosis, marginal ulcers, gallbladder stones, internal incisional hernia, or short bowel syndrome. However, the metabolic complications or nutritional complications will include nutritional deficiencies, dumping syndrome, postprandial hypoglycemia, nephrolithiasis, bacterial overgrowth, osteoporosis, bone disease, psychological and social, as I mentioned earlier, and weight regain. So these are the ones that on the yellow, basically, I will cover today. And most commonly, these three components, which is nutritional deficiencies, metabolic and endocrinological complications, and weight regain. Those I will cover in details. So we have the first poll as well here. So the question is, what is the percentage of patients that come back with weight regain after bariatric surgery, do you think? Okay, that's actually the correct answer. It is 25 to 35%. Oops, I think I still, yeah. So we have the answer, the most common answer is 25 to 35%, which is the correct answer. And it is, if you think about it, it's actually a large number of patients would regain the weight post-bariatric surgery, but this is depending on multiple factors. And I will talk about weight regain as the first complication post-bariatric surgery. So in order to define weight regain, we have to know what is the trajectory of weight post-bariatric surgery. And this is a very important assessment when you see the patients after surgeries. Usually you will see them after 1 year. So they will pass a period, what we call nadir in surgical weight, which means that it is the lowest weight that will be recorded after surgery. And it happens usually after 1 year up to 18 months during this period. So this is from again, same study where they actually trended the weight of patients after surgery up to 3 years. And here you can see in patients with post-Roux Y surgery, they will have their lowest weight around 1 year, and they will plateau usually after. And then the regain will happen sometimes after 2 years. So they define the nadir as the lowest weight after surgery around the 12 to 18 months. And then you calculate what is the total weight loss that this patient lose. And the reason why you calculate this is you want to see if this patient actually reached the target that's required from the surgical intervention. And this is also depending on the surgery, which I will mention on the next slide. But in order to calculate to calculate the maximum total weight loss, you will need your baseline, the baseline of the patient, and also the lowest weight they achieved. So sometimes they will come to you and they did not reach the lowest weight, so that's okay. After 1 year, however, and a year and a half, they should have actually their lowest weight. So, and then the patient will start regain slightly or plateaued in the weight. So you divide basically the, sorry, you, sorry?
What's the meaning of nadir? So for people to know.
Yeah, so nadir is the lowest weight after surgery. Nadir weight is the lowest weight after surgery, which means the dip in the graph in the patient's weight. So basically, you calculate it by subtracting the pre-op weight from the nadir weight divided by the pre-op weight to give you the total weight loss that the patient had. And there was many markers that was studied actually to check whether the patient reached the target or not. One of them was how many units of BMI did they drop, but this is not considered a very useful marker for calculating the trajectory, because most of the guideline used the total weight loss. So the current total weight loss, meaning the current weight, you are using the current weight instead of nadir in calculating the patient's weight loss. The types of surgery and the weight loss. So the most common surgeries we have in Oman that is done is sleeve gastrectomy, number 1, comes first, followed by gastric bypass or mini gastric bypass. That actually go for Roux-en-Y gastric bypass. So usually in Europe, also when anastomosis gastric bypass is trending, sleeve gastrectomy is most common in America, and in Canadian basically practices, usually the Roux-en-Y is the primary procedure, and basically some patients will have sleeve, but Roux-en-Y will be the most common. So depending where you practice, you will see the majority of patients post-bariatric surgery. That's why it's important to know what type of, basically, what is the target weight loss that is achieved by each of one of these, and what are the indications. But this is usually in the pre-surgical evaluation that we might talk about in future presentations. So the sleeve gastrectomy, the total amount of weight loss you expect from sleeve gastrectomy is between 25 and 30%. And while Roux-en-Y is between 30 to 35%. So this is what is expected usually from these type of procedures. And then you have one anastomosis gastric bypass or mini gastric bypass. It is between 35 and 40%. And this is considered a little bit more malabsorptive than Roux-en-Y. And it is more complex to be done for the surgeon because it has one anastomosis instead of 2. And then we have the SADIs as well. SADIs are growing interest worldwide now, but we don't have that many data, but it is similar to one anastomosis gastric bypass, which is about 35 to 45% of weight loss. So if the patient comes to you and they did not achieve this amount of weight loss, then you start questioning why the patient did not achieve the expected weight loss. Is it suboptimal weight loss? And suboptimal weight loss has not been defined well by the guidelines, but some study defined it as they are losing less than 20% of the total weight loss at 12 months mark in general for all type of surgeries. So less than 20% is considered suboptimal weight loss. And then the weight regain, again, there is no consensus in terms of what is the definition of weight regain. The only guidelines that defined it was the Canadian guideline when they mentioned that it is defined as 25% regain of total weight loss. So this is considered very small percentage. For example, if the patient lost, if the patient lose 100 kg, they regaining 25 kg would be considered a weight regain. Why this is important? Because it is one of the things that you, as a primary care physician, you might require you to investigate why this patient's not losing much after the intervention. So it can be multifactorial. One of them is actually the most common cause is nutritional indiscretion and physical inactivity. Most patients think that after the surgery, they can basically, it will limit them from eating. So that's okay to basically to go back to their old habits, but they will eat only small amounts of food. So this is a very, big misconception, because most patients will regain because of the habit recidivism, where they will actually go back to their old habits after a while. and it will cause weight regain or suboptimal weight loss. And then the second reason sometimes is malnutrition. What I mean here is usually nutritional deficiencies that can actually hinder any weight loss, including iron deficiency anemia and vitamin B12 deficiency, was thought to be associated with why the patient do not lose weight that much. And then endocrinological causes and metabolic alterations for the patient. They might require like going back on medication that can cause weight regain is another reason. And anxiety, eating disorder, and also the last usually cause of weight regain is anatomic surgical failure. Anatomic surgical failure is usually we think of it last thing because we have to exclude the other causes first, which is the most common. So step one, basically we correct any nutritional deficiencies in management of patient with weight regain and also fix any malnutrition. Lifestyle intervention post-bariatric surgery, we have to emphasize the importance of lifestyle after bariatric surgery because it's a tool as any other tools that we use for weight management. If the patient does not follow strict lifestyle after bariatric surgery, there is a high chance of regain. Then for our management as step one, you can use other pharmacotherapy as you will use them prior to surgery, except for orlistat, which is not recommended if the patient have a malabsorptive procedure. But you can use, for example, GLP-1. Now, this is here in Oman, we can use it in patients who are diabetic, or patients can buy, for example, from outside if they can afford it. So you can use it as a first step if your patient comes back to you with the weight regain. Step two, if there is no weight loss and you suspect anatomical failure. Now this is rare, but the case I'm presenting is actually, it has something to do with this, but usually either you refer to bariatric surgery for basically investigation of anatomical failure if the patient is following a diet and was suboptimal, I would say, more than a weight regain. Then you start suspecting those anatomical failures that can include, for example, fistulas or basically stricter fistulas mostly, or in bypass patient. And for example, a pouch, gastric pouch in patients post-leave as well. So also you can discuss with the bariatric surgeon if there is a revisional procedure that can be done for this patient. So you refer them back again into the same system where they get assessed pre-operatively for a revisional procedure if basically the first intervention failed. And usually the weight loss after revisional procedure is less than the weight loss from the primary procedure. So we usually sometimes pick those cases very carefully if they require the revisional procedure. So before we move on to the second topic, we will have the second poll, which is it is around the same topic, but it would be basically launch and regarding of management of weight regain and lifestyle intervention. What is the minimum protein requirement post-bariatric surgery?
I think we reached 70% of the answers, Doctora.
Yes. So we'll end the poll. So we have 50-50 here, but it seems like majority thought it was 0.5 to 0.8, but actually the correct answer is 1 gram to 1.5 grams per kg of the body weight. It might seem a lot to you, but this is as per the guidelines is actually there is a controversy whether it is per total body weight or the ideal body weight. Everybody follows the total body weight, most of the guidelines, which is 1 gram per kg per day. And this is with the minimum. So they recommended the minimum, for example, in the Canadian guideline, which is 60 grams per day, up to the 1 gram per kg. So it's very important to focus on the protein intake for different reasons post-bariatric surgery. And this is one of the things that we usually stress for patients post-bariatric because of the protein malnutrition, the muscle loss, as it will cause osteoporosis, the reason the protein intake. So there are 7 rules that you have to screen your patient. If you have a dietitian in your primary care setting, she also has to screen patients, or she or he has to screen patients for those 7 rules. They have to eat 3 to 5 small meals per day. Skipping meals is not allowed at post-bariatric surgery because it can cause multiple complications, like including dehydration, orthostatism, as well as hypoglycemia. So what is recommended is usually 3 to 5 small meals because the patient's portion size will be very small after surgery and it should not increase. So they would have three major meals and snacks in between. The second rule is to chew food slowly because that prevents dumping syndrome. If they basically have unchewed food or a large portion of food, then that will lead to dumping. So chewing food slowly is very important. Minimum of 6 grams of protein per day, which can be divided into 3 meals as 20 grams per meal for patients. And they have to learn how to calculate their protein intake. And this is what's recommended in sleeve gastrectomy and gastric bypass. However, if a patient have one anastomosis gastric bypass or duodenal switch, duodenal switch is not done in Oman, but it is the most malabsorptive procedure where protein malnutrition is very common. But one anastomosis gastric bypass is common. So I will aim for a higher minimum, which is 100 grams. And the only place where I can find more information on one anastomosis gastric bypass is the UK guidelines. So the fourth rule is basically they have to separate liquid and solid by at least 30 minutes. No carbonated drinks or caffeinated beverages, no alcohol intake. And this is important also in preventing dumping syndrome and also helps the patient to have enough nutrients because they will be very full if they drink before or after like the meal immediately or with the meal. So with the abdominal pain and also dumping. So these are the habits that we usually focus for the patient, and the only liquid that they are allowed usually is water. And what we have seen here, most patients think that juices are healthy and they increase their intake of juices, and this will lead to other consequences because it's high glycemic index. So it might cause hypoglycemia and dumping as well. 2 liters of fluid per day to prevent orthostatism, which is basically the hypotension when they complain of basically getting dizzy very frequently, or for example, dehydration. So that's why we have to emphasize on 2 liters of fluid per day. No smoking or NSAID use, or basically direct oral anticoagulants, because those will lead, especially in bypass patients, because they might lead to anastomotic ulceration and bleeding. And then activity, the recommended activity is 150 to 300 minutes per week, and this is moderate intensity exercise. It helps preserve the muscle after surgery, because as you might know, that after surgery they will lose 20% of their muscle mass. So the only way to prevent that loss is actually by activity as well as increasing protein intake. Then nutritional screening. So all patients post-bariatric surgery should have annual screening and for nutritional deficiencies. And for any, whether it is by signs or symptoms of deficiency or biochemically. The recommended screening parameters biochemically for post-bariatric patients will include the CBC, looking for basically anemia, urinary electrolyte, mostly for looking for dehydration signs, iron profile, ferritin, calcium, vitamin D, PTH, vitamin B12, and folate. The addition of other vitamins that is done abroad, actually not in Oman, but it can be a referred test, above for the Roux-en-Y and one anastomosis gastric bypass, with the vitamin E, zinc, and copper as well, because most of these deficiencies happen in malabsorptive procedure compared to restrictive procedures like sleeve gastrectomy. But the common misconception is that patient post-leave gastrectomy do not require annual screening, and this is wrong. Usually everybody require annual screening post-bariatric surgery. So the third poll will be I might have answered this already, but patient post-leave gastrectomy do not require lifelong multivitamin supplementation. Okay. Okay, so I think I will end the poll here. So that is correct. That's false. Patients post-leave gastrectomy actually lifelong vitamin supplementation. The misconception that is causing patients is that if they have a sleeve, then they require only multivitamins for 1 year. And that's wrong. They usually require multivitamins lifelong as well. So what are the multivitamins that I give to patients post-bariatric, or what is recommended basically by guidelines to give patients post-bariatric? So we don't have that many multivitamins in the market that is specifically for bariatric patients, but we have 2 right now that I would recommend patients to take. And as we all know, maybe we don't provide multivitamins in the government hospitals, so patients has to buy them. And this is very important to discuss with patients even before they go for bariatric surgery, that it will require them to buy multivitamins, and this is lifelong supplementation. So what I that they can find in over the counter, basically in the pharmacies. And what I recommend is actually women 50 plus, but many patients has been complaining that they cannot find the women 50 plus. They will find usually the regular multivitamin. So if they find the one from A to Z Centrum, it is recommended to take 2 tabs per day. In addition to that, I give them 50,000 units a month of vitamin D, in addition to the calcium vitamin D daily, 500 milligram plus 400 BID. Why? Because the recommended vitamin D post-bariatric surgery is actually 3,000 units a day, and this will give them around that if you give them 50,000 a month, in addition to daily calcium vitamin D. And of course, this is not necessarily lifelong for calcium and vitamin D. This can be titrated according to their levels, but initially post-bariatric, until you repeat the level, which is annual, then you can basically adjust that. If the patient is willing to buy basically the 1 pill multivitamin that's specifically designed for patient post-bariatric surgery, there is one here in Oman in the market where they can contact the supplier and buy the Forte, which is basically 1 tablet. The good thing about this, they will not need an extra vitamin D, but they will need only calcium carbonates to be added, which is around 500 milligram TID. So this is the regimen right now that I found here in Oman that is following the guidelines in terms of the levels of the multivitamins that they need. However, both those regimen would require B complex in addition, which is also over the counter. The patient should buy the B complex until we repeat the levels and their vitamin B12 is normal, then we can discontinue. And also for the iron, only if the patient is deficient, has a deficiency at the baseline or known for iron deficiency anemia. Usually I give it also for menstruating women because it's very common to have iron deficiency anemia that's usually worse in post-bariatric. Necessarily to mention to the patient because of the above regimen that they should not combine the iron and the calcium together. So the rest of the supplements, apart from the multivitamin, can be titrated according to their levels. So they can stop the calcium and vitamin D if they have normal calcium, normal PTH, because secondary hyperparathyroidism is common post-bariatric surgery, especially the malabsorptive ones like bypass. or vitamin D level above 75. Of course, unless your patient has a fragility risk, for example, patients who are postmenopausal, have a family history of fracture and so on, then you have to continue the calcium and vitamin D supplementation. So in terms of the nutritional supplements, supplementation, there are so many issues that is basically around to them because they require multiples. We don't have calcium citrate, which is actually the preferred type of calcium supplementation in post-bariatric patient because it prevents calcium oxalate stone formation. But we don't have it here in the pharmacy and also not in the over-the-counter pharmacy. The other thing is affordability of the multivitamins. I have few patients who are complaining that multivitamins are expensive. The Centrum, for example, will cost about 10 riyals a month because they require 2 tablets per day. With the B complex, maybe it will be an extra additional cost. However, for example, the Forte will cost about 70 riyals for 3 months. So some patients will not be able to afford those medications, which is an issue, especially if they have malabsorptive procedure. We also have a few liquid chewable multivitamins. Because of the pill size, sometimes they would complain they are not tolerating the patient, the vitamins. So there is one multivitamin that is in a chewable form. It's called Baricol Complete. However, this is only in one private pharmacy here in Muscat that belongs to one of the private hospitals. So it's not very accessible. Single pill format, we don't have it accessible in many pharmacies, as I mentioned earlier, and also compliance. So these are the issues that you will struggle with patients when you see them in regards to the supplementation. So if the patient brings their own multivitamin and asks you if this is okay to take because of the price or because of, for example, they can't tolerate it, the size of the pill, and so on, you can check if it is complying with the guidelines or not, because this is from the Canadian guidelines, and also it is similar to the American guidelines, where you check the levels of the vitamins if they will need 1 pill, 2 pill, according to the levels. They are quite similar between them. The differences is mostly in zinc and copper. They require higher in duodenial switch. And we don't have this procedure here in Oman, but we have something similar that I will talk about later. I think that we have a question. Somebody posted a question. Either we leave it to the end, I think.
We leave it to the end, Shaf.
Okay. So so you can check basically if those vitamins that they prefer they can use it based on what are the recommended levels based on the procedure. So the one part that I would not basically discuss much about today, but you might face as well, is pregnancy post-bariatric. What is the recommended multivitamins? In general, you can actually switch the regular multivitamin into the prenatal vitamin, which is important because the contraindication is mostly that we regularly use. So they recommend actually switching to the prenatal vitamin because it should not exceed vitamin A should not exceed 5,000 units as well. So that's one of the recommendations. And then the folic acid needs to be in a higher doses. Other than that, you can switch them to prenatal vitamin with additional folic acid, and the rest will be the same. Treat any deficiencies if exist. So the most common deficiencies you will see, because we talked about many vitamins, but the most common deficiencies you will see: iron, vitamin B12, usually in 2 years after surgery, vitamin D, thiamine is in specific cases. I've seen it very frequent here actually. Zinc and copper is also common in malabsorptive procedures like Roux-en-Y, like mini gastric bypass as well. So either you screen them, as I said, by checking the levels, but some of those vitamins we don't have it available. So it's very important to know what are the deficiency, the symptom deficiencies that patients might present, and what are the risk of this patients having specific deficiency. For example, vitamin B12, you might expect it to present at 2 years and above post-surgery. However, if a patient at a baseline had low vitamin B12 and it was not replaced before surgery, and then they might present with actually significant deficiency immediately post-op. So also in addition to that, patient taking metformin. So sometimes the first drug they go back to after surgery, if they are diabetic and they relapse, is metformin. So addition of metformin might worsen vitamin B12. So in these cases, you need to replace vitamin B12. So the most common presentation, macrocytic anemia, as we all know, neuropathy, cognitive disorders, very common, and peripheral neuropathy, as you know, gait disturbance, and so on. So the replacement, the thing is, in our pharmacy in the government, we don't have PO, and this is a good thing, I guess, because IM is considered better, parenteral replacement considered better in vitamin B12 compared to PO. So what I usually give, I give 1,000 microgram weekly for about a month, like 4 weeks, and then I give them a maintenance dose, which is a 1,000 microgram monthly. There is, if you repeat the level and the level is around 600, it's okay. There is no toxicity. You can continue with the maintenance dose or switch them to PO. So, so there is no harm of giving enough vitamin B12, or if they are in the normal level, do not stop it immediately or rush to stop it, but give them a maintenance dose. In regards to vitamin D and calcium, so we know that the patients, the end presentation will be like osteopenia, osteoporosis, cramping, hypocalcemia, and tetany. So we usually try to prevent it before it reaching that stage. So that's why it is one of the supplements that we give to the patients right off the bat, like in the beginning. So if they are deficient, however, like we replace them on a higher doses, for example, 50,000 unit weekly for a month, and then I give them 50,000 unit monthly. And then the daily 2,000 unit, I used to give it, but they told me it is restricted only to pediatric for some reason. So you can give the 50,000 units monthly for patients to replace the vitamin D. In case you repeated after 1 year, of course, you will repeat the vitamin D, calcium, and so on. If they are in the normal level with the PTH being normal, then you can't stop the, unless they have a risk factor, you can stop the supplements. Thiamine deficiency. Thiamine is usually associated, go hand in hand with malnutrition. And this has happened in patients who have a persistent surgery, whether it is to mechanical causes or other causes or psychological or so on. They might have a significant thiamine deficiency. Don't wait for the measurement of thiamine. You can just replace it because it's a symptom. If you suspect it, just replace thiamine. Usually happen 3 months post-op. Patients who take alcohol or persistent nausea and vomiting. One of the common basically presentation you will see is there is a wet beriberi, and the other name for it is a wet beriberi or dry beriberi. So dry will be like confusion, disorientation, neuropathic symptoms, constipation, while wet they present as a heart failure. And this is usually a late stage. You might not see it in primary care that much, but the replacement, if it is like only dry, then you can give them a PO replacement, which is 100 milligram up to TID actually, or BID, until symptoms resolve. The same thing, you can give them an IV replacement. If you suspect it though, and because it's associated usually with malnutrition, make sure that you don't give glucose with it, or high glucose nutrient, or IV glucose, or for other reasons, because that will worsen thiamine deficiency. And you have to replace other electrolytes, including the potassium, phosphate, and magnesium flow, because they will worsen after thiamine replacement. So iron, I think you will see daily, because it is very common, especially in menstruating women at a baseline, let alone if they have a bariatric surgery. So the common presentations, but the most common frequently presented symptoms post-bariatric is actually it's pica, which is they like water with ice. So you will find that very classic symptoms. Replacement is a PO usually, unless sometimes they are symptomatic, then you can give them or refer them to hematology to give them IV therapy. But they should respond well to the ferrous sulfate if they are basically if they are compliant with the medication. So you have to separate it from calcium because of the absorption. The patient will already They take either 2 hours apart, or they separate the supplements, and it's preferable to take them with vitamin C supplements, like the tabs of vitamin C that they can dissolve in water and drink. So that will increase their absorption of iron. The other nutrients that is basically maybe less commonly seen, they are light presentations, especially in patients who have a significant malabsorptive procedure. Then you can see zinc, copper, or vitamin A. For zinc and copper, we don't have testing here in Oman, so you have to refer the test basically abroad to get it done, unfortunately, unless you know of a center in Oman that measure them, but I don't. So basically, symptom-wise, they might present usually with a skin lesion, poor wound healing, dermatitis, especially if they have diarrhea, that will be actually worsening zinc deficiency, altered immune system, and so on. So zinc replacement is no consensus in the guidelines for zinc replacement. We do have a zinc oral here in the Ministry of Health replacement, and if you suspect it, you can do it, but it's preferable to have a baseline level to avoid toxicity. So zinc to copper ratio is usually 8 to 15 milligram per 1 milligram of copper. Why this is important? Because replacing zinc alone without replacing copper will cause copper deficiency because they compete at the binding site. So you have to give them together. And if you higher the dose of zinc, then you will need to increase the dose of copper as well. So the issue with the replacement is that in the guidelines, they don't have clear duration. ACMBS, they said we don't have basically a regimen that we can recommend because there is no enough data, while the Canadian LAC, they put the replacement but without a duration. So in the UK guidelines, however, they mentioned that you can, if the copper is borderline low, you can give the patient, if the zinc is borderline low, then you can give the patient 2 tabs of multivitamins consistently and then repeat it in 3 months. It might improve. That's the only needed basically intervention for borderline. In regards of copper, suspected if a patient have a persistent iron deficiency anemia despite replacement, and we don't have replacement therapy here in the Ministry of Health, but they can have an oral therapy that can be bought actually from outside. I will actually move a little bit faster because we are taking a bit of time on nutritional deficiency. But the most important thing in copper, if you treat iron deficiency anemia and the patient did not respond very well, then you suspect that if they have a malabsorptive procedure and they have leukopenia. So you check the hematological indices as well, like the CBC of the patient. Vitamin A, again, not measured, and available replacement maybe is available, but I'm not 100% sure. And basically the dosing will be depending on the presence of ocular presentation or not, like night blindness or ocular xerosis. That would be with ophthalmology confirmation. So I think this is important to mention that about the new procedures, which is the one anastomosis gastric bypass as well as the SADIs, because they are common here in Oman. So the issue with these 2 procedures is that the recommendation for nutritional deficiencies can be different. And the only guidelines that covered those 2 procedures, which is the UK guideline, mentioning that Roux-en-Y can be if the lymph or the loop that is bypassed in 50 centimeter, you can give the same replacement of the Roux-en-Y. But if it is more than 150 or it is SADI, then you have to consider more severe malabsorptive procedure like duodenal switch. And the reason I'm mentioning this, because I had a case actually a couple of weeks ago where I had a female, 45 years old, had one anastomosis gastric bypass and cholecystectomy 2 years ago. She is non-diabetic, more than 20 years on insulin prior to the procedure, and she was known also for dyslipidemia. She had a total weight loss of 19% from her nadir, which was the lowest weight, and that was 74 kg from her baseline, which was 97 kg. And when she came with a bit of regain, which was 83, actually not a bit, it's 50% because she lost about 20 kg almost, so 83 kg. So the patient, 3 months after surgery only, she had an A1C of 9.9 with impaired also glycemia. So her fasting was around 13 and 14. So she was restarted on metformin, and following that restarted on liraglutide and then insulin eventually. She was not taking her multivitamin, prescribed calcium and vitamin D and iron sulfate, complained of tiredness and fatigue. So when she came the couple of weeks ago, her hemoglobin was 7. She had low MCV, MCH. She had low vitamin B12. Her calcium was normal. Her iron was very low, and her vitamin D was 54, which is considered borderline, but less than 75. So the concerns for this case was the suboptimal weight loss, 19%, which is less than 20%, and the weight regain at the same time, the profound iron deficiency anemia, the compliance to multivitamin and the multivitamin deficiencies, and also diabetes remission, which is after a malabsorptive procedure. Basically, she relapsed immediately after. So in terms of the suboptimal weight loss and weight regain, the causes for this patient can be different. It could be habits because she had a low intake of fiber, low intake of protein, her portion size has increased, and also she was taking high carb dense meals. Inactivity due to social circumstances. The patient has a lot of stress, and this can be a factor in weight regain. Her mother diagnosed of cancer, husband diagnosed of cancer, so at the same time. So it was basically one of the major factor, I would say. And then medication, insulin. As she went back to insulin, she required high doses of insulin after surgery. That will also lead to weight regain. Last thing after all these three was the anatomical failure. So I suspected it because it was immediately after post-op. The patient had she had no major weight loss during in the procedure itself. So it was in my mind, but mostly because of the three above causes, it was most common. The surgical team thought it was not, they would not further investigate anatomical failure. So again, other nutritional factors included the iron deficiency anemia and the stress. So in terms of the management, of course, this patient had other more important or critically important factor that I will mention on the next slide, but lifestyle intervention was reinforced low carb, high protein diet with meal replacements. If the patient is not tolerating the protein, or they are busy, they cannot basically provide enough protein in their diet, they can use supplements on the market that is with high protein, for example, glucerna with high protein or protein max and so on, to basically get them enough protein in their diet. The idea was also with the lifestyle intervention is to lower insulin. So the second part was treatment of iron deficiency anemia, and I treated this as an emergency because one of the things that you have to rule out in patient post-bariatric surgery, if they present with such iron deficiency anemia that's significant, is to rule out upper GI bleed, because marginal anastomotic ulcer is common in these patients as well. And then the second differential was nutritional deficiency and menstruation or heavy uterine bleed, which he denied actually. So the top of my list was to rule out the upper GI bleed and the marginal anastomotic ulcer. The patient was referred to local hospital for blood transfusion, and then OGD was arranged, and it is happening next week. And then basically after the transfusion, she required 2 units, but she was vitally stable. She had no melena. She had no, other than basically the significant anemia, she did not have any symptoms of upper GI bleed. But we treated it as such because it's important, and then maintenance of iron supplements. Her symptoms of anemia has improved after the transfusions. So compliance to multivitamins, we did stress the fact that she need to be compliant with the multivitamin, especially when I went back to her surgical notes. She had an OHGB with a 200 centimeter, which means that the bypass in her is significant. Actually a higher dose of multivitamin supplementation because of the according to the UK guidelines, it should be similar to the duodenal switch. So I would recommend, ideally, I would recommend that you will take Forte. and instead of the 2 tabs of multivitamins, but the patient had an issue, like limitation in terms of the finances, so we're not able to do that. I replaced her IM with the vitamin B12, higher doses of vitamin D, and recommended further investigation to be done, like for example baseline BMD and INR, because that will give us an idea about her vitamin K, copper, and zinc as well. INR only on the Canadian guideline basically recommended in patients with the duodenal switch, not all patients. But here, because we have OAGB frequently dying, I would recommend actually measuring INR. Now we come to the endocrinological complications. So in the endocrinological complications, we can cover like the hypoglycemia and the bone health. So dumping syndrome has been divided in the guidelines. There's different terminologies and it can be confusing. So dumping syndrome, there is early and there is late dumping syndrome. So the early dumping syndrome, which is referred to, this is mostly harmless, but it's very symptomatic to patients, which is usually happen after first hour after meal, 30 minutes to an hour after a meal. It's usually associated with high fat, high carb meals, and large portion meals. It can happen in all bariatric patients, regardless to the procedure, whether it's sleeve or bypass and so on. Usually the symptoms is abdominal pain, severe diarrhea, nausea, and vomiting. The classical symptoms will be the patient saying that after eating immediately they have to lie down because they felt that they will faint. So this is very common. There is no documented hypoglycemia. There should not be any documentation of hypoglycemia with early dumping. And it can happen early post-operative. So for example, less than a year post-operative, it is common. So dumping mostly because of the type of food, and also it is there is no hypoglycemia. While late dumping, which is also another name for post-bariatric hypoglycemia or postprandial hypoglycemia, it can happen 2 to 3 hours after meal. And it is usually associated with high glycemic index food, for example, that has high sugar. So, and it mostly happens in malabsorptive procedure compared to sleeve gastrectomy, but I have seen it very frequently in patients with sleeve as well. Usually the symptoms are mostly neuroglycopenic symptoms of hypoglycemia, fatigue, weakness, confusion, hunger, eventually syncope. Syncope is rare in early dumping, but it can happen with the late dumping. And this is more serious because they will have hypoglycemia that can have catastrophic consequences. And basically, this is usually seen 1 to 2 years post-operative, but it can happen also earlier. So in terms of why this is happening for early dumping is mostly because those type of food, the high fat, the high carb or dense carb, can be a very hyperosmolar. When it reaches the duodenum, it can stimulate different hormones, including incretins, that will lead eventually to a symptoms similar to hypoglycemia, but without documented hypoglycemia, like vasomotor symptoms, GI symptoms, and hyperglycemia, in fact. While late dumping is mostly with the rapid glucose absorption. That's why it's mostly with high glycemic index food. And it is usually due to hyperinsulinemic response. And that would lead to a hypoglycemia, a documented hypoglycemia. So again, as I mentioned, like it has in the literature, you will see it is named differently: postprandial hypoglycemia, late dumping, hyperinsulinemic hypoglycemia as well. Recent studies has shown that hypoglycemia can be associated with the weight regain. So when the patient present with weight regain, usually also they present with the hypoglycemia. So there is an association. The second thing is pre-existing diabetes. This is controversial. They say it's not always protective. If the patient is diabetic from before, it is not necessarily they will not have a post-bariatric hypoglycemia. You will see some patients actually develop this after who were diabetic, and they will develop hypoglycemia after. So these two things are like these two features, which is the dumping early, whether it is early or late. They can be so severe that it will lead to reversal of the surgery itself. And it is the second most common cause for dumping for reversals, up to 9%, while the hypoglycemia itself can be up to 8 to 5%, which is the third common cause for reversal of the surgery. Now, management of the post-bariatric hypoglycemia. First, you need a careful history to differentiate between the early dumping or post-bariatric hypoglycemia, because as I mentioned before, both of them, one of them is somehow benign. The second one can be serious. We need a confirmed hypoglycemia. Patient should be recommended to check their glucose if any of these neuroglycopenic symptoms happen. And we need to exclude other causes, always like if suspected. So if there is a features of other causes like Addison's or hypothyroidism and so on, you check those basically levels. If the patient's taking other hypoglycemic agents, where those patient diabetic and on oral medication, they would think that they have to continue their oral medication. So you need to stop them. However, there is no evidence for checking baseline and CPI, although frequently done, but there's no evidence that they are not hypoglycemic at the beginning. The only the only treatment, but it is the most important treatment, is actually diet. Most patients will not require anything but the diet, the dietary control, and the dietary control including low carb, low glycemic index diet, and adequate protein intake. And even the sequence of eating the food can make a difference. For example, if they start with the protein and then the carb, can reduce the incidence of hypoglycemia. And of course, avoiding high fat and also restricting alcohol and caffeine that has been associated with the hypoglycemia. So the type of food is very important, and how they eat is very important. They should avoid at all costs all the high glycemic index food, because they will present with the hypoglycemia afterwards. So mostly diet. If there's no improvement with diet, then you might refer to endocrinology to exclude other causes if you suspect like insulinoma or pancreatic hypertrophy that's sometimes seen in post-bariatric patient. And this will be confirmed by either 72-hour fasting or mixed meal test. Sometimes in the Canadian guideline, usually they skip the second part where you need to refer to endocrinology, but also give pharmacotherapy if you suspect that the patient quality of life has been, worsened because of these frequent hypoglycemia. Then you might add pharmacotherapy like octreotide diazoxide, acarbose, calcium channel antagonists. I have used acarbose before, but not the others for the same reason. Surgical intervention is the last resort. If the patient, after all the above, did not, basically the hypoglycemia is very frequent and it was not controlled, then you might refer them to surgery for different alternative. Most commonly is reversal of the procedure. This is what is usually done for patients who cannot basically did not improve with the above measure, the medical management. I always recommend patients, and this is from the American guideline itself, that I recommend patients who have a frequent hypoglycemia or complain of symptoms of hypoglycemia to buy the continuous glucose monitor, because it will help the patient basically have an association between different meals and the hypoglycemia, and also physician to monitor the frequency of these symptoms and whether it is in relation to food or not. And it will basically help also patient control their diet. So this is the second case, which is a patient who is diabetic for 6 years and was on oral.
We have already 10 questions and already we have 1 hour and 10 minutes.
Exactly.
There's a long time. Do you have long time to go, or shall we suggest that to get questions?
That's actually 2 more slides. I would skip the case.
Okay, good.
And basically 2 more slides to talk about osteoporosis, because this is also very common post-bariatric. Yeah. And so osteoporosis, mostly because of the nutritional deficiency, which is vitamin D and calcium, leading to secondary hyperparathyroidism, leading to bone resorption. Baseline BMD before surgery is not always done because of the BMI of the patient and the machine itself and so on, but it is recommended to have for all patients, especially post malabsorptive procedure, to have 2 years post-surgery BMD to screen for osteoporosis. Osteoporosis risk. However, avoid bisphosphonate post-bariatric surgery, especially they did sleeve because it will worsen GERD and also the risk of ulceration in bypass surgery. So the other alternative from the guidelines is IV zoledronate, which is 5 milligram in 1 year, or denosumab. And also you have to replete calcium and the vitamin D before starting those medications. Other complications like kidney stones, you might see it 1 to 4 years after surgery, mostly malabsorptive procedure because of the calcium oxalate stone. The mainstay treatment is calcium citrate. Patients, sometimes they stop calcium if they were told that they have a stone because of the misconception that the stones can be caused because they're taking frequent calcium, but it's actually the treatment, not the cause. So calcium citrate supplementation is important, increase hydration, and also low-fat diet. Protein malnutrition, we already mentioned this, and we also mentioned the take have to screen all patients post-bariatric for evidence of depression or suicide, body image, or eating disorder. This is common even in Oman. I have seen it frequent in post-bariatric patients in the last 6 months. So all patients should be screened post-operative for mental health and referred to basically to a specialist if it is needed. So finally, I'm sorry that I took a long time because it's a big topic. So bariatric surgery is an effective tool, but it has to be used appropriately in a comprehensive setting. The role of primary physician is very important in a lifelong management and care of the patient. Always encourage your patients post-bariatric surgery, even if they have come back with a little bit of weight regain, to encourage them to do self-monitoring post-bariatric surgery, whether by weighing themselves, have a habit goal, or a specific goal-centered approach in order for them to continue the journey of weight loss, because bariatric surgery is not the end. And this is my references, and thank you. We'll go back to the question, I think, now.
Yeah, thank you, Dr. Amira. I mean, just we'll get like a quick question and answer. So for the time, we have a lot of questions here, and if somebody wants to ask verbally, they can raise their hand. I will take them accordingly. And Mariam, I mean, she's asking me for how long we need to evaluate nutritional deficiencies. I mean, till how many years post-op?
Annually, there is no specific timing. There is no end point where they can stop doing the nutritional assessment. All patients should have an annual checkup.
Yeah. What about fasting Ramadan? I mean, when can people start practicing the fasting of Ramadan post-bariatric surgery?
So this has been discussed in one of the meetings, actually, in post-bariatric surgery patients in Ramadan. The year they do the bariatric surgery, it's not recommended for them to fast. And if they have, for example, if, however, they have frequent symptoms like that contradict them fasting, like, for example, frequent hypoglycemia, then it's not recommended also to fast. So initially, the only recommendation that was which should not fast, and then the year after you can.
Okay, great. About the question about the bone health and the DEXA scan, and with the unavailability of DEXA and all of the governorate, it is how, when shall we start screening, with these resources?
So, with limited resources, I would advise first, if the patient have a malabsorptive procedure, then they should be priority for screening. Second, if they have a high risk of osteoporosis. For example, if the patient have a previous fracture, already high risk if they are not already on treatment, or the patient is taking medication, for example, immunoresorptive, or for example, steroid therapy, and so on, they should be screened for osteoporosis, depending on their risk score.
Yeah. About the pediatric weight control surgery, is it your field, or can we touch this question? About
sure.
Yeah, the question about the indication of surgery, what type of surgery it's preferred, and how much we expect to have weight loss post-op, and a question about, do you have a national guideline in obesity in the school age group, Victoria?
So basically, bariatric surgery for patients above the age of 17 is done. is covered in the guidelines because they are not specifically pediatric guideline, but there is more and more now studies that are covering pediatric patients, including teen labs study that is in US, basically checking whether the rate of complications related to obesity in pediatric population has significantly reduced with bariatric surgery, and they have really good outcome. Now we have a few referrals from pediatrics for bariatric surgery, and I think the youngest was done for a 10-year-old from my pediatric colleagues, from what I heard. There is no difference in terms of right now, there is no difference in terms of the surgical care for pediatric or adult. The post-operative outcome in terms of the weight loss, we don't have much data, but the teen labs study, which is mostly for teenagers, showed the similar results in I had answered the questions, but I'm not sure. There is pediatric guidelines for obesity management, but not like a surgical, the surgical part.
Great. About the question about when ladies can plan for pregnancy post bariatric surgery.
Very good question. I wanted to touch on this topic, but as you can see, it is very limited time. About a year, 18 months. Actually, most guidelines would recommend 18 months post surgery, not less than that. We will have to consider the age of the patient, of course. Sometimes they do the surgery for infertility. Their age is usually above 40 sometimes. So, however, minimum should be a year.
Yeah, great. What about some centers they give vitamin B12, monthly? For how long, they should give it, and how much? The guidelines say yearly, checkup of vitamin B12 levels. Is it for how long? These centers could give B12, monthly injectable session. It did not specify it is a deficiency or non-deficient.
So as I mentioned, the maintenance for vitamin B12, they can give it monthly for a year. They can check again the level in 1 year. And then when they check the level in 1 year, even if it was in the normal range, you can give the choice to the patient to shift to PO as a maintenance. But again, they would have to buy the supplements because we don't have it available in the pharmacy and Ministry of Health, or they can continue taking IM or IV. IM is probably commonly given monthly, but if their vitamin B12 is normal and they don't have symptoms, you can give them a choice to switch to PO.
Yeah, a practical question. Patients who have done surgeries in private sector or outside, can they follow in the endocrine center or the local centers? Usually in our center we follow up. Yeah. Usually in our center, like in Nizwa, Nizwa follow up, cases have been done in private sectors. I don't know about the endocrine center.
Yeah, so because the endocrine center is specialized in patients, basically assessment of patients on the surgical stream, some of our patients on the surgical stream end up doing the surgery in the private. So they come back for their follow-up appointment after that, after surgery, for basically baseline checkup and for complications sometimes and so on. Although we don't basically necessarily follow outside patients in the center who are not in our surgical stream, I mean.
Yeah, great. But the question about the pregnancy and nutritional supplements, some centers like gynecologists, they don't prepare to put patients on calcium, with vitamin D. Others, they have different, I don't know, guide, recommendation. So what's the usual recommendation of the nutritional supplement in the pregnancy time?
So basically, sometimes we switch them to prenatal multivitamin, and the rest, the calcium and vitamin D, if they are low, then we replace it. If they are normal, then we stop it or hold it during the pregnancy. So there is no specific contraindication that I know for calcium and vitamin D during pregnancy. In fact, if they have a malabsorptive procedure, I would recommend them to be on calcium and vitamin D.
Yeah, about question about also the requirement or suggestion to have post-bariatric nutritional services. Training for nutritionists and also a team the specialized team to look after this surgery. Do you have a national intention to build up such teams?
We currently we have dietitians who are seeing patients post-bariatric patient, also under training for seeing patients post-bariatric. We are planning to have guidelines, including recommendation for post-bariatric patients to follow. This is in the plan. Training for dietitians, I think that would be something we can do in the future at the National Diabetes and Endocrine Center. Like dietitians can maybe join us also for further training.
Yeah, I mean, sometimes pregnancy could happen. I mean, like we got like a case of post-bariatric, 3 months they get pregnant. I mean, any special consideration if they get earlier pregnancy on such earlier time?
So it is a risk not only for the mother, it's a risk also for the fetus. So they should be followed with obstetric and gynecology frequently in a high-risk clinic. Frequent follow-up in terms of compliance to their medication, as well as basically fetal monitoring and so on. This is what I would recommend for now, but usually there is no clear guidelines of what to do if they got pregnant less than a year post-surgery, but definitely those patients would maybe face a bit of complications in terms of through their pregnancy course. But the most important thing is to comply with the recommendations. Like they take their multivitamins, they follow in a high-risk clinic. This is what I would recommend.
Yeah. Can people go into keto diet after bariatric surgery? Like some people, they don't achieve like a good significant weight loss or the weight regain. Can they go for keto? Very low carb diet.
So this is an interesting question. It does apply similarly to patients who are pre-bariatric or like patients with obesity. Although keto is more into post-bariatric friendly diet, because in post-bariatric care we do emphasize on high protein intake and we do emphasize on lower carb intake. However, the keto diet should include a healthy fat, but they will still need that nutrients, including carb, because it also helps in the muscle loss. I will not advise necessarily keto, not that I'm against it, but they should be between 60 to 120 grams per day, comparing to keto, which is less than 40 grams per day. So I would recommend the lower carb diet instead of keto and more emphasis on protein and healthy fats. I think that's what I would recommend, especially in patients if they have a malabsorptive procedure. So malabsorptive, this would put them in more risk of developing like stones, like the keto diet and malabsorptive procedure in terms of like stone formation because of the higher fat intake. So that would be one of the caveats only that I would mention.
Yeah, and I think they could increase the risk of constipation and dehydration on this issue.
That's true. That's true too.
Yeah. The question here comes up also like the, I mean, more of like a lifestyle-oriented question. I mean, there is like a big trend to go, I mean, like to say for surgery earlier than doing lifestyle intervention. And a question, why don't they give a time for lifestyle intervention before you go for surgery? And how long you need to go for lifestyle change before like to make a decision on surgery? Is it like the level of BMI or previous experiences or whatever it is?
So as I like in the guidelines, let's say preoperative weight loss is not necessarily a mandatory. Like it is not a mandatory requirement for them to have a surgery to have a preoperative weight loss. However, most guidelines recommend that patient would try lifestyle intervention before attempting bariatric surgery and it failed. However, in certain conditions, we know that lifestyle interventions are limited. For example, the total amount of weight loss with a lifestyle intervention you can achieve is 15%. And this is enough sometimes to improve multiple comorbidities, including diabetes, osteoarthritis, GERD, OSA, and so on. However, sometimes it's not enough if there is like significant mechanical complications like osteoarthritis in terms of improving the pain. So surgery might be a better treatment, especially if they also diabetes. With the diabetes remission, has shown to be more significant in bariatric patient. So first, we follow the criteria. The criteria is usually not our criteria, but like, for example, the cases. The general criteria by guidelines, it's usually above 35 with comorbidities or above 40 without comorbidities. They can go for bariatric surgery. However, I do recommend patients to be on a lifestyle intervention at the time of applying for bariatric surgery. There is a wait time for the surgery to happen, usually 6 months, usually a year. But during that time, they should actually show they are compliant with lifestyle, because this do not have major complications post-op.
Great. I mean, like very few questions. Use of contraception post-bariatric surgery. It is a specific advice or what preferred method?
Yeah, so for gastric bypass and or other malabsorptive procedure like one anastomosis, gastric bypass, or SADI, and so on, they should not use oral contraception because it is not absorbed well after surgery. This is number one. So they should use other than oral contraception. For sleeve, it's okay to use oral contraception if they want to. The other preferred will be IUD. Especially sometimes if a patient have a heavy like uterine bleed, then IUD like hormonal with the prior surgery would be maybe ideal for those patients. So, or other form of contraception like transdermal and so on.
Yeah. What about the gallbladder disease? I mean, do we need to screen pre-op, and do we need to put them on medication to prevent gallbladder stone? And what's the criteria here or recommendation?
So usually we in the clinic surgeon basically screen all patients with abdominal ultrasound for gallbladder disease, because if they have a gallbladder disease, then they would perform cholecystectomy at the same time of the procedure. And if they don't have a gallbladder disease, they would have only the bariatric surgery done, and following that, they would put them on uridoxicolic acid to prevent stone formation for 6 months. However, I think there is another like trial coming up to basically to see if this practice is actually evidence-based or not. But currently it is done by most surgeons. They put patients on uridoxicolic acid for 6 months.
Yeah, great. About the thyroid function test and thyroid disease, do you screen for TSH like frequently on a regular level post-bariatric surgery? Or it's not recommended?
Usually the annual screening would be enough for TSH. And if the patient is symptomatic, of course, you have to do it earlier. And if the patient have suboptimal weight loss, you have to do it as well. If you suspect it to be a cause, if the patient has a previous screen that was normal, no TPO, then positive, then maybe you would need to do it even more frequent. So depending on the patient.
Yeah. And what is the age limit to do the bariatric surgery and the above age limit? There's like a question, is it 60 or we can do?
Yeah. So most guidelines would say 65. Well, it's actually center-based.
Okay.
Center-based, but mostly 65. However, it's been done like for patients older than that.
Yeah.
It depends on the functional status of the patient. If they are like very fit, 70, for example, and they can benefit from bariatric surgery, or 65, but they're very fit, then why not?
Yeah. What about, a question about, do you expect to have ketonuria post bariatric surgery?
Interesting question. I don't know the answer to that, but they are not in ketosis unless they are in starvation, like ketosis. They are malnourished, like they will be on a keto diet. But I'm not sure that it is something that's prevalent post bariatric patient.
Yeah. About some patients they get like some, cold extremities on and off. Is it related to any nutritional or hydration, issue, or the sympathetic parasympathetic dysfunction?
So it is common to see after any acute weight loss, cold intolerance. It's common, even if it was medical weight loss, but it was acute, they would usually present with cold intolerance. Dehydration could be one of the reasons. I'm not sure of other one, which is like the sympathatomimetic or anything like that, but it is common to see in patient post-bariatric.
Yeah, great. I think there's one question. I mean, somebody raised hand, Dr. Jamila, if you want to give her a question verbally, she can speak it up. Unless by mistake she put the raise hand arrow. Dr. Jamila? I think it could be by a mistake. And by the end, we'd like to thank you, Dr. Amira, for your long session, but it is very informative, and we'd like to get another session, something to discuss more in details some of the issues, and of course by the end of the session we'll get like an email with the certificate and the evaluation form, and you'll get also the links for the guidelines and the presentation slides, and of course you can access our presentation on the YouTube after a few days, inshallah. Any final comments, Dr. or message, Amira?
Thank you, Dr. Zahir, for the opportunity, and I apologize for the long presentation. Hopefully in the future we'll have more topics covered that is important to primary care.
Inshallah. Thanks a lot, Dr. Again, Amira, for the talk, and see you inshallah in the second session inshallah next week. It will be inshallah either about the fatty liver disease and or common ophthalmic condition in primary healthcare. See you there and enjoy your coming days and years, and good night. Thank you, Dr. Amira, and thanks all.